Good evening or good afternoon or good morning, depending on where you are, everyone. Thank you very much for joining us for this Nutritia Podinar, which is the first of three. Thank you very much. I know these are not easy times for anyone, and I think all of us have got a bit of Zoom fatigue sometimes with these meetings. So I think it's really testament to the quality of the other speakers and also Tasha's organisation that we've got such a good turnout today. I think we want to make this as interactive and clinical as possible. Obviously, there's a theme around the microbiome and the gut, but really, I think personally, the relevance to most of us who are clinicians in both the audience and those of us who are speaking is really to try and answer any questions you feel. I think there's an opportunity for you to answer questions. We may not answer them straight away, but we'll bundle them up together and get the views of our experts. So essentially, there are two hosts for this meeting, myself, Rupert Hines. I'm a paediatric gastroenterologist at Monash Children's, and Dr. Shannon Brothers, who's a paediatric allergist in New Zealand at Starship. We also have two additional guests today. I'm sure many of you will know all three of the other speakers, and certainly Sam Mayer as a paediatric allergist at the Royal Children's. I have to say, on a personal level, I refer a lot of patients to Sam. My most challenging patients, where the gut overlaps with allergy, I send to Sam, and they really are a tricky bunch, I must say. I'd also like to welcome Vincent Ho, who's an adult gastroenterologist who has a significant clinical interest in both teaching and also research around the microbiome. I think we have to recognise that adults have a microbiome too. It's not just about paediatrics, although a lot of the focus and research obviously is because of the most important influences of those first 100 days. I think we all recognise. So the way we are going to play this one today, and happy to have some questions in real time if things are not going smoothly, is I'm going to present a clinical case. I think there are features that all of you guys will recognise from your clinical practice in the audience, and I think Shannon and I can then get views from ourselves, but also views from our learned guests about where they would go clinically in that situation. If that all makes sense, I'll start the slide presentation. I think if you've got some tech issues, I know you can post them. Shannon and I, Sam and Vincent will not be able to answer most technical questions, but I know Tash will be able to answer some of those in real time. So look, I'll start with the clinical presentation, but please, ask away as you see fit. That's me, obviously. Some disclosures, but it's not really relevant apart from the top few. So I guess, Vincent as an adult gastroenterologist will absolutely see patients who are before the mum gives birth. She'll want to, try and prevent allergy because they're an atopic family. And certainly, as paediatricians, ideally babies don't come out early. And I should say, as an aside, which is not really relevant to this topic, that there's been a dramatic reduction in preterm deliveries in most developed countries during the COVID-19 pandemic for, a whole host of reasons, which is clearly a good thing that babies are staying there a bit longer. Anyway, this is a patient that I looked after long after this. I'm not a neonatologist, but certainly this was a baby who was born early. His mother had preeclampsia and he had an emergency cesarean section. Like many babies in this situation, because he had some respiratory distress, he was given some empirical antibiotics. Now, obviously, none of us is a neonatologist, but certainly there are strategies to try and diminish antibiotic use that neonatologists use now. But certainly, sick little babies, the downside risk of group B strep is far going to outweigh any concerns around the microbiota when you've got a sick little baby. Anyway, this baby himself did actually very well. He had some CPAP for a few days, and then actually, fairly rapidly, after some IV fluids, progressed onto breastfeeding, initially via a nasogastric tube, and then breastfeeding from about 35, 36 week when his swallowing was well developed. So actually, all in all, he did pretty well. There were no other neonatal concerns, no neck, no eye stuff, no brain stuff, and he did really very well. So eventually he went home at about 36 weeks of age. His mum did a great job. I don't need to tell anyone who's breastfed a baby how difficult it is, but to express for 6 or 7 weeks for a preterm infant before you start feeding is a huge achievement. And she was keen to do that, having breastfed a previous child. At about 3 or 4 weeks of age, he had some postprandial irritability, so she was breastfeeding him, but he was a bit angry, didn't really finish his feeds on the breast sometimes. Hadn't really lost any weight, but not unreasonably. Well, that's not the only explanation. The family doctor diagnosed some reflux and started a PPI. Now, obviously, PPIs equally have their potential downsides in terms of the gut microbiota, but they are a good treatment of reflux. Then about 3 or 4 weeks later, this baby presented again, now a couple of months of age, and he was having bloody mucousy stools about 8 to 10 times a day. His mother noted that even though she was keeping up to date with his nappy changes, he's getting a really sort of that sore excoriated bottom. And equally, even though, he was having the squirts, as it were, these were bloody mucousy stools, he had a lot of discomfort and pain and straining around it. So I suppose maybe to the I guess my co-host first, and then and then Sam, as a paediatric allergist, this is a situation that you'd see very commonly in clinical practice. I suppose what would your sort of initial thoughts be with regards to this baby? I'll go with Shannon first. What would you do if this mum said, "Look, I'm really worried about my son, Shannon, this pooing is getting out of control"? What would you tell her to do?
I guess I'd want to know that he was otherwise healthy and growing well and developing well, and that all other systems checked out okay. And then I think the most common thing I would be thinking about it that after that, if everything was normal, would be calcium protein proctocolitis.
I agree. So the baby was thriving, as we know these babies often are, and all the other sort of stuff that related to prematurity was good. There were no other concerns, and certainly he was doing everything appropriately developmentally. So I agree. That was exactly my thoughts. So I suppose maybe I'll ask you, Sam. So we've got a mum who's really keen to breastfeed. We've got a child who almost certainly clinically has an allergic proctocolitis. What advice are you giving to this mum if she wants to do something, but she wants to breastfeed?
Yeah, so I mean, I agree with Shannon with the first bit. So they need to be thriving, they need to be healthy, and there need to be no warnings about other things going off. So if they had a fever or they're profusely vomiting all the time, I'll be thinking about a different condition, for example. If they have severe eczema and they've got bloody stools, as an immunologist, you get a bit thinking about that, particularly if that was a boy, and then you're thinking about immune dysregulation disorders, for example, rare hen's teeth stuff. But you're trying to just make sure you've excluded everything entirely possible before you go down that road, which is most likely, as you said, Rupert, this is food protein-induced allergic proctocolitis.
So just to that end, Sam or Shannon, I mean, I guess we'll talk, even the non-immunologists amongst us recognise the link between the immune system, the gut and the skin. But actually, clinically, there are probably more babies who've got a bit of eczema and allergic proctocolitis who don't have a formalised immune deficiency. So I guess my question is, let's just say this baby, when would you actually think, hold on a minute, this baby may need some at least preliminary investigations of the immune system? And if so, what would you do? Or would you wait and see how the baby went? This is for both of you, really, Shannon and maybe Sam, in that order.
So from my perspective, in New Zealand, we have really high rates of, in particular, autosomal recessive chronic granulomatous disease. So I would, so I have a slightly skewed perspective when you put a baby either for X-linked chronic granulomatous disease or autosomal recessive in front of me in our population. And so I'd want to know, had there been any other boils, abscesses, any needing incision and drainage, any perianal abscesses, persisting fistula, those sorts of things. And if there were any red flags there, I would have a very low threshold for doing a neutrophil oxidative burst, particularly in a boy with but that's obviously a very skewed perspective, because that's not going to be very common generally.
No. So I suppose then, Sam, to pose it the other way around, let's say you've got the baby who's got none of those things, to be honest. This is a healthy kid, right? He's not had skin stuff. He's not had weird stuff around his bottom. You know, he's an atopic sort of kid from an atopic family, but you're not worried about this kid. So I suppose then the question is, what advice are you giving to this mum that this is not the patient who's arrived at the Royal Children's with all manner of concerns. This is now the child you're seeing in rooms, you know. What advice are you giving to this breastfeeding mum in terms of her child with allergic proctocolitis?
So the sort of first question to ask around her diet. So what are you eating? Have you excluded anything? So usually by the time they're coming to see me, they've gone and spoken to 1,000 other people, probably gone to Facebook, mothers forums, and usually eating air by the time they arrive at my doorstep. If that hasn't happened and they're fresh off, then, as you know, the most common trigger of this would be cow's milk protein. And so really the question is, are you having dairy? How much dairy are you having? Have you seen an actual correlation between, once you've had dairy, do you find that there is clear days when your child is worse? There's much more mucus and blood. And can you find that association? Sometimes they can't. But sometimes they'll give you a history of, yes, that the days I have too much coffee in my milk is the days that's terrible. And it's just the careful manipulation of the diet, trying to work out how much dairy do you have, how much soy do you have egg in your diet? Because they're the three triggers really that you're concentrating on about the next level of exclusion if they haven't done that already.
Yeah, no, agreed. That's exactly what we face. They've often tried a few things, haven't they? So Shannon, let's just say we are, as we often are. So the mum's already on a 4-food exclusion. She's on cow's milk, soy, wheat, egg. I'm with you, Sam. I worry about the mums, and I think, where are you getting your calcium from? How can you live on lettuce leaves? You know, you've not only had a pregnancy, you're now breastfeeding. You know, you've got to look after yourself too. And I make that point all the time. So if a mum said to you, Shannon, look, I've done this 4-food exclusion. We've still got some ongoing blood and mucus. We've still got the same well baby. I really think it's allergy. Can you give me any other suggestions as to foods I should exclude? Would you at that point say, apart from ones where it's obvious in terms of clues, you wouldn't? Or would you ever recommend extended exclusions in clinical practice? Shannon, if this was a baby in your rooms.
I worry about those mothers as well who come in. I think that's a very good way that Sam put that, eating air. And we do see them, and not just worried about the mothers, I'm worried about their babies getting enough nutrition and calcium. And I would not recommend extended food exclusions in those situations. In fact, usually what I find myself doing is backtracking some of those and saying, well, let's focus on the most important 1 or 2 food groups and exclude those fully, because often there are little bits creeping into the diet that they're not aware of.
Do you see merit in I don't know, do you two send the mums to a dietitian, both to hone the exclusion and to help themselves nutritionally, or would you just have a chat and say, read up about it yourself? Do you feel dietitians have a role? Because I often think they do, for both reasons, for both the mum and, you know, for herself, and also for the detailed exclusions. I think, you know, dietitians have a big role here, actually. The problem sometimes, and I think Sam's alluded to this, is that A, people have got support elsewhere, sometimes not good advice, and B, it takes a while to see one of the 3 of us, and then it takes even longer to see, you know, an experienced paediatric dietitian. But if they can, I do feel they have a big role. I don't know what you two think.
Absolutely. I would refer a baby like this and their mother to a dietitian. I'd also suggest the mother goes to see their GP to possibly prescribe some calcium supplementation if necessary.
What about you? Sam, do you just go, because I often just say, well, I pick an arbitrary adult amount of calcium that I know to be suitable, and say, if you're excluding dairy and soy, you're probably not getting enough calcium. Take it. Do you do that, or do you do a more nuanced approach to their calcium supplementation for the mums?
No, I do the same as you, Rupert. I'm assuming once I've taken out cow's milk and soy, where they actually get the calcium source from. Often they'll go and have almond milk or rice milk, and particularly with the rice milks, there's hardly any nutritional support in any of that. So I'll just arbitrarily say, listen, go and take yourself on the caltrate, 600 milligrams, while I'm doing this to you.
Yeah, agreed. Yeah, so I think we're all pretty much saying the same thing. I think we all probably wouldn't investigate this baby unless there were other red flags or systemic features, in which case we would think about, as you say, immune deficiency. But most of these babies are not like that. They're often, as you know quite well, the diagnosis is clinical. I think there's no reason whatsoever for me to consider endoscopic investigation. It's absolutely unjustified. And I think, we're all saying that, the culprit foods are the three you've alluded to. Beyond that, it's not very useful, and it's just almost punitive for parents, isn't it, really, for mums who have had enough of it by the time they've taken 4 foods out, and there's just no evidence for stuff beyond that.
Sorry, Rupert. I was just going to say that sort of other red flags for me. I mean, Shannon's alluded to the boils, and you've sort of said it before. There's eczema and there's eczema, right? So some of these will have concurrent eczema on top. So the stats are roughly about 25% of food protein allergic proctocolitis will have some level of eczema. But if there's severe eczema and you can't control that eczema, you're having difficulty, and they've got bloody stools, just be wary. Why is that? Why can't you get that eczema under control? Particularly in a boy, then I'll even be more wary if they're having bloody stools. And the other red flag you've already alluded to is the failure to thrive. So if you've got a kid having profuse bloody stools and they're failing to thrive, that's not cow milk protein induced proctocolitis, right? Be much more worried about those kids.
I would agree. I think often sorry, Sam, you're right. I think often this kid, even though he's pooing 10 times a day, he or she, the classic ones, are just, they're happy, sort of fat, chubby babies, and it's only when they do a poo that they're a bit grumpy, really. So I completely agree. Yeah.
We had a case at the Royal Children's Hospital, just to prove the point, of a child who had mucousy bloody stools, who was 3 months of age. All intents and purposes, that should have been, food protein induced allergic proctocolitis, but they were failing to thrive. And it took a while to people realize, and they looked at that child's lymphocyte count, and that child had SCID in the end. And, they'd been on an elimination diet. It wasn't working. The mother had then, reduced a number of allergens. That wasn't working. And it was only until someone went, hold on, this is weird, let's do a full blood count. And then it was lymphopenia was it picked up.
So the point is, even a simple test, lymphopenia is always worrying in a baby. That you don't need to do your immunology fancy pants test to sort of think about SCID, do you really? That's going to... Correct. Lymphopenia always needs an explanation, doesn't it? I think people sometimes ignore it.
Yeah, that's exactly right. Or thrombocytopenia even, right? So it doesn't take a fancy test. If it doesn't fit, it feels a bit weird, just do a full blood count. And not always will it be picked up, but lymphopenia and thrombocytopenia will change the direction where you go.
Absolutely. So I suppose just moving on. So we face these babies too that either because the baby's got ongoing bleeding, or because the mum doesn't want to breastfeed anymore because she's struggled with the exclusions. She says, "Look, I'll start with Shannon. Look, Shannon, I don't want to breastfeed anymore. Like I feel like I've given it a good go. I've sort of resigned myself to that decision. I'm not unhappy about it. I want to start a formula." So I suppose both at a practical basis and also at a evidence research basis, what sort of formula are you going to recommend for this baby? And I suppose it's a sort of a 2-part question. Are there situations when you would take the next step rather than going at a sort of a level entry milk in terms of risk of lack of response? I hope that makes sense. What would you do for this baby in particular, who's if mum wanted to stop breastfeeding? What would your formula choice be, Shannon, and then Sam?
So how old is the baby at the point that
the baby is now? Let's just in real life, this baby was about sort of 4 or 5 months of age.
Okay. I guess if this baby was over 6 months of age, even though soy can sometimes be implicated, that doesn't mean it always is. And often it is just cow's milk protein induced. So over 6 months of age, I would be thinking about soy formula as an option. And then under 6 months of age, be thinking about extensively hydrolyzed or amino acid based formula as alternative options with more evidence base for, well, probably better response rates for with extensively hydrolyzed, with amino acid based formula.
So is there, just to go back to that sort of 4-month-old baby, is there any situation where you would say, look, I'm just not going to bother with a hydrolyzed feed, I'm definitely going to go straight to an amino acid based feed? Or would you, because there's obviously the societal pressure in terms of costs, isn't there, to go hydrolyzed for amino acid based formula? The costs are quite different. I mean, not as different as they used to be, but is there a baby you'd say, I'm just going straight to the amino acid based formulas, Shannon, or would you always give that hydrolyzed feed a go first?
It may somewhat depend what your regulatory requirements are. And so we would, in New Zealand, not off the bat, get funding for an amino acid formula in this situation without first having tried an extensively hydrolyzed formula. To go, just talk to the New Zealand experience. And that's Pharmac driven in terms of special authority criteria.
Sam, same question to you. Any kid that you would go straight to an amino acid based formula, or do you generally give the hydrolyzed feed to go, or do you always go to amino acid based formula? What's your clinical practice and what's your understanding of the evidence as it underlies that choice?
My pathways of choice are something like, if an elimination diet hasn't worked, and we're talking about formula, I just want to tell you what I do in that situation. I normally go cow's milk, but usually what happens is I go cow's milk and soy because the parents have waited a while to come to me and they want resolution pretty quickly. So I almost lump it together and go, right, I need to solve this for you pretty fast. So let me do it together. Now, some people may disagree and go, well, we should do cow's milk first and then wait for the week and then eliminate soy for the next. But you're so busy, like practically speaking, everyone is busy and you're trying to make a quick solution for that problem really fast. And given the whole feeling is there's a 40, like Shannon said, it's not 100% crossover. It's something like 40 to 60% may have cross-reactivity between the milk proteins. But that's enough for me to wipe it out. And if you haven't responded after 72 to 96 hours, which is the philosophy, then I'll go, right, let's do egg next. And if you haven't responded, then the fourth most common trigger based on research is corn, would you believe? But then once you've done corn to someone, you've almost killed them because it's in everything. And so if that doesn't work, then I'll go, right, my regulatory body says I need to do an EHF formula because when I call and they'll say, I have to say, you have tried cow's milk, soy and EHF. But I find that people that I see really are desperate to breastfeed. They're really hung up on it, and not hung up, but they want to do it. And so they want resolution of that problem with elimination rather than to go on a formula.
Agreed.
And so sometimes if I haven't resolved the problem, then I have to be very clear with them of what we're trying to resolve. So I'll say to them, if you've got mucousy stools, that will not get better, and that's all you've got. I tend to find that doesn't get better no matter what I do. You could go and eat air again and you'll still have mucousy stools. And usually I find in my personal experience, it's once I start solids for that baby, does that mucus go away?
So I guess you're separating mucus from mucus and blood. I would say the same. I think, you've got to accept mucus, otherwise well-child bit of mucus. I think I'm sure we'd all do the same clinically. But I suppose my question more to you is, and I share all of those views. You've got the parents who just want to carry on breastfeeding, and if you've got an otherwise well baby, why would you switch? But I suppose in a child where the mum wants to or there's blood, at what point do you pull the lever with a formula, and what would you recommend to that family?
I'll pull the lever on the formula when the mother is now exhausted, really.
Yeah, agreed. Yeah.
Where I think you are probably doing more harm to yourself than any good. That you've eliminated so much out of your diet with no clear resolution, with bloody stool still, that I need to resolve that problem for you very quickly. And so in those circumstances, you know, I tend to have a tin of amino acid formula in the room and say, I haven't done an EHF, but you've been struggling a long period of time, and let me just try this for you. And so that's when I've done straight to amino acid formula, and seeing if they responded. Obviously, then you get into this problem of you've just jumped into an amino acid formula, you haven't done an EHF, so what are you going to do now? But if I've resolved that problem pretty quickly, it's hard to then justify to go back to an EHF. You know,
Agreed.
so I've just gone, fine, amino acid worked, let's just go on amino acid.
Yeah, and
the only thing.
Sorry, you go, Shannon.
Sorry, so the only thing I'd say to that is I will sometimes also have a discussion with the parents, with that exhausted mother, and kind of go, this is a mild benign condition, where I guess I would have a chat to them about the fact that this is not doing the baby any harm. I'm not saying that we don't need to get rid of that blood or mucus, but actually we don't need to stress as much about it if we are confident that we've excluded anything nasty or rare. And so I don't see it probably from the same perspective in terms of being in a rush to get rid of it, if they're on board with that. If they're not, then clearly there is a rush because they are going to exhaust themselves.
Yeah, I mean, I think it's the mother that you pick. So there'll be some who will be on board with it, that you'll go, the mucus doesn't matter. And they're totally fine with that. But the ones that we tend to then screen into coming to see an allergist, immunologist, are the much harder ones, where there've been weeks of this, where they want a resolution of that problem. And they're the harder ones to convince that this is, and I agree, like this is a benign condition. It gets better over time. There's great studies done in the past where mums didn't exclude dairy or soy in the diet. Actually, they didn't do anything. They just kept on feeding as they normally did. And some of those children got some iron deficiency anemia, but by around 12 months of age, it all resolved anyway, without any dietary exclusion, and nothing terrible happened to those kids, either during that period of time or in the long term, right? But that's hard when a mother's gone into that zone of, this is bad, here's 1,000 poo photos on my phone, I'm going to show you each one and email it to you. And they're so fixated on it that they want the resolution of that problem. And so they're the hardest ones to convince, don't worry about it, this is nothing.
Oh, and look, totally agree.
Yeah, agree. I think it's, I mean, you get the family where there's just occasional blood, you know, so mucus every day, but blood once in a while, but there's no obvious trigger in the mum's history. I think many parents are happy to, in a sense, sit on that for the reasons you've alluded to. And we can say confidently, can't we? It's a benign condition, will resolve. But you're right. I'm with you. I think, you know, certainly when you've got someone whose child's going 10 times a day and the mum's fixated on the blood, it's very hard to say, well, look, it's a benign condition, you know, you're going to be right. But even if we know it is. And look, I suppose what we've all just talked through, and I think we all share the same views really, is that, you know, maintaining breastfeeding where possible is clearly useful. There may be a role for soy, although less in the little children. And I guess hydrolyzed feeds and amino acid-based feeds are both good at turning off blood, you know, one slightly better than another, but both very good. And I think, once again, we'll probably all do fairly similar things with that. So that's probably enough of that. So I suppose, you know, this is where I'm sort of keen to hear from the allergy immunologists amongst you. You know, obviously the whole business of, you know, where you see probiotics having a role, you know, what advice, you know, you would give to parents of a previous atopic child, you know, both in terms of what you actually do clinically and also, you know, what evidence you think is good in this space. So more at the allergy prevention sort of level for mums, you know, when do you do it? Who do you do it in? And when do you use probiotics in babies in your clinical practice? And I suppose, you know, I'll also perhaps bring Vincent into this afterwards to say, when does he advise? Because he must, you know, some of your gastro patients will be, you know, pregnant mums. You know, what advice do you give them as well? So maybe if we start, you know, with Shannon and Sam in that order, and then Vincent, you know, when do you recommend your parents either give themselves probiotics, the mum, obviously not the dad, and when do you recommend that the the babies are given them? When do you, in clinical practice, plus or minus, where it fits into your understanding of the research in that space? So, Shannon.
I guess in clinical practice, we know, well, we think we know that probably the earlier probiotics are given to pregnant mums, that's going to make a difference, but we need more studies in that area. And I'm not usually seeing mums when they're pregnant early on, or when they're pregnant at all.
It's more for the next child, I suppose, because
yeah.
you've got a patient and I'm pregnant again now. What shall I do? Dr. Brothers, you saw, saved my life fixing this baby, but what do we do next time?
I don't know that we have enough information, is what I tell them. And certainly when it comes to the baby in front of me, we don't have enough studies, but also the studies that have been done don't show any protective effect for food allergy itself. So I am not prescribing probiotics in my clinical practice. I may be out of step, but I don't know that there's any evidence yet, or enough evidence.
And I suppose I flip the question the other way around. What about if a mum said, "Look, she's read the literature, she understands something about allergy prevention, and says, look, I want to take probiotics in the last trimester, of my next pregnancy. I believe there is some evidence. This is the mum speaking, not me. And then can I give the baby some as well? Would you say, well, that's okay, or try to talk her out of it, or what would you say in that? Because I get that question not uncommonly, and I'll come to Sam in a minute. But
I wouldn't try to talk her out of it, but I would say that that may be helpful. It's not going to be dangerous, but we don't know that it's going to prevent food allergy. Also, the last trimester may be too late, from what we know in terms of studies that are evolving.
No, it's hard, isn't it? And Sam, where once again, it's both clinically and in terms of your understanding of the literature. I guess the Royal Children's have done a fair few analyses of probiotics that may or may not be helpful, depending on which of their studies you read. But what's your use of them clinically? And furthermore, what do you think the evidence tells us that we could do either safely or effectively?
I think clinically, I haven't prescribed probiotics as a therapy, full stop. I just find sometimes in these patients, particularly with, active colitis like this, the whole concept of let's give something natural, let's just fix the problem by giving a probiotic, can actually sometimes exacerbate the situation, so that the mum will give a probiotic in the kid who's got active colitis, and then can make that situation, that colitis, even worse. So I haven't done it. There's no evidence to suggest that in particular the condition that you've just presented, Rupert, that it makes a difference whatsoever. So I'm pretty firm with that, and they'll say, should I do it? And I'll say no, because there's no evidence, and it could potentially make it worse once you've got active disease. I think we're bad at prevention of allergy, and the only thing that I think we can do for prevention of allergy is probably not around probiotics, because as Shannon alluded to, what dose, what probiotic, when are you going to give it, who are you going to give it to? And if you have a look at all that, it's so convoluted that it's impossible as clinicians that we can give any practical advice to a patient sitting in front of us and say, go and take that probiotic strain, and that will make allergy reduction happen in your child. So the only thing that I think works is early introduction of allergenic foods between 4 to 12 months of age. If we're trying to reduce the risk of IgE-mediated food allergy, we've got evidence for that now, with the LEAP study and EAT study, which is the early introduction of peanut and egg. And so my mantra has literally become all done by one, as fast as we can we get these allergenic foods in between 4 to 12 months of age? And my personal philosophy has been, and it's a turnaround of how I got trained to where I've come now, is in the past we used to screen all these kids, with eczema, and let me do a skin test and let me find out what you're allergic to. And so we've come full circle now and said, actually, I don't think we should do that. We shouldn't be screening with the kids between 4 to 12 months of age to a food you've never eaten, because I can cause a false negative reaction. or at worst, I'll cause a false positive by a screen test, then tell you not to eat the egg or peanut based on a test that has a high false positive rate anyway. Now I've made the situation, I've medicalized something that I shouldn't have. Of now making you avoid that food, and now you may become allergic to it because of a test. So now it's this introduction. Go hard.
And would you give the same advice to the child from the atopic or the non-atopic family?
Yep. Yes, absolutely. I think this whole, it sort of ballooned out of, it came when it was about, children who had eczema and an egg allergy. That was the sort of basis of it all.
Yeah.
But I think it's just ballooned out, Rupert, into the ether, and it's become to everyone, to every baby between 4 to 12 months of age.
So a question back to you then, Shannon, before I go to Vincent. In these kids who are having, I guess, gastrointestinal symptoms of non-IG mediated allergy, do you see any role for skin prick testing any of these kids?
I don't.
The allergic colitis has got some mild eczema? No, okay. And that would be the position of most allergists at the moment. Is that fair to say?
Yeah, absolutely. There'd be no role in this with this baby, and even if this baby had some mild eczema, I completely agree with Sam. If we test, we pick up mild sensitization, suggest avoiding that food, or even if we say it's fine, go and have it, go and introduce it. The parents may go home, exclude the food, and we've contributed to development of a food allergy that may never have developed, and we're then left with a long-term problem that we've caused.
Agreed. So perhaps to summarize both of your views, like many of us, you have a degree of uncertainty around the role of probiotics. I think we're optimistic about them, but they hadn't really delivered apart from some of the initial studies, which really long-term weren't great. So we're probably all saying that we don't actively discourage them unless it's someone with active colitis, but we don't necessarily recommend them as part of our clinical practice. Would that be a fair summary of your two's views?
Yes.
Yep.
Okay, good. Maybe just to go to Vincent. So Vincent, when you're seeing your female adult patients who are contemplating pregnancy or who are pregnant, who are atopic, or they come from an atopic family, or they've got a previous child who's atopic, what sort of conversation do you have with them with regards to allergy prevention, probiotics? Because I guess you probably do get some of those questions, as well as the obstetricians antenatally, if you happen to be seeing them in that time before they actually have the baby. What sort of chat do you have with them as an adult gastroenterologist?
Great question, Rupert. And certainly I do see pregnant women, particularly in the last trimester, that have heard a lot about the benefits of probiotics. And one thing I want to say sort of echoes what Sam mentioned before, and that is when it comes to probiotic studies, the challenge is the fact that the design of the studies and the heterogeneity of the studies means that we don't know a lot about dosing different strains of probiotics. So as far as standardizing evidence that we give to mothers, that is rather challenging. Certainly, we know from the World Allergy Organization, they've got some recommendations, which are that certainly pregnant women that have a high risk of having an allergic child, women who breastfeed, infants at risk of developing allergy, and infants at high risk of developing allergy. That's the target group, according to the World Allergy Organization. We know the evidence for that is not particularly strong. I mean, it was considered a sort of a weaker recommendation, but nonetheless, it was a recommendation. We also know, Rupert, that there have been studies done, and certainly there was one large systematic review done early this year, which looked at maternal probiotic supplementation during pregnancy and lactation. And whilst there was probiotic colonization of the infant gut microbiota, there was actually limited evidence of effects on bacterial diversity. So there wasn't really a lot as far as probiotic supplementation breast milk bacterial counts for healthy women, but they did find that lactobacillus probiotics, if you give that to women affected by mastitis, it actually helped to reduce staph loads. So that was actually interesting. So my advice is that is a practical one, that if there's interest in a probiotic, I do feel that they're generally very safe, and I would support that use, Rupert. I believe there is some evidence that it does actually change the colonization of the infant gut microbiota. How that actually plays as far as modulating the immune system is extremely complex. And so while there may be recommendations and guidelines to support that, I do think it comes down to individual and personalized choice.
Agreed. And I think, it's no surprise to anyone, is it, that if you give an infant a probiotic of any sort, you're going to see it in their stool. But the question really is around its persistence in that child's stool. So, adding a probiotic to a formula, that it'll do what you think it'll do. It'll be there. And that just tells you that the manufacturers are clever at putting probiotics that don't die in formula. But I'm with you. It doesn't necessarily tell you about the long-term benefits for that child's microbiota. Just to remind everyone in the audience, we're very happy to take questions. And certainly between Shannon and I, we can look at them in real time. And if it's particularly relevant to a bit we're talking about, or furthermore, we can look at them all at the end, and we can all work through the questions. I don't know, Shannon, if you can see any questions at the moment. I'm not sure.
Yeah, so there's one question here. Maybe Vincent, this would be a good one for you. From Wendy: if a mother has group B strep in pregnancy, then requires, say, 1 dose of IV antibiotic in labour, would breastfeeding for 6 months be able to correct the gut microbiome for that baby?
Yeah, I mean, it's a really good question. So, unlike women who are undergoing cesarean section, which require intrapartum antibiotic prophylaxis, we know that if you're undergoing vaginal delivery, generally, antibiotics aren't required apart from those that test positive for group B strep. And this is what we're talking about here. And we know that it's actually very common. It's found in about 20 to 30% of pregnant women at the time of delivery. So it is important to treat that, because if you don't treat that, that means that infants can be born with sepsis, they can have bacteremia, meningitis. I mean, these are rare but serious complications. So certainly there is a need to treat this. Shannon, I do think it's very important. Obviously, the antibiotics are going to affect the infant gut microbiome, and we know that there are some changes that happen. For example, we know that quite often there's a decrease in bifidobacterium, a very good bacteria, and an increase in Clostridium species. So there's certainly alterations in the gut microbiome in these women that have had treatment with antibiotics. But what's very interesting, and I guess I'd be interested in my other panelists here, is that often, despite the fact that there are some drastic changes very early on in life, we do know that around 6 months of age, the differences between infants that are born vaginally and by cesarean sections, those differences actually largely disappear. And certainly around 12 months of age, there is really no difference. So there is a difference early in life, yes, but how that actually translates to a difference in immunological outcomes is where it's very interesting. Does that difference, and I think this is where there's a lot of research, does a difference early on, which eventually disappears by 6 months largely, and by 12 months, does it really lead to a difference in risk of allergies, let's say in childhood? Does it lead to a difference in the risk of developing adult diseases later in life? And that is where there's a lot of research in this area.
That's a good point. And I think it's still very much in its infancy for innumerable reasons. One, it's very hard to randomize these things. Two, there's so many confounding variables. And three, the gut, a bit like the ocean, has so much in it that we don't know about. And certainly, there are lots of bacteria particularly that live in anaerobic spaces that we know nothing about. So you're right, it's hard to know, isn't it? And I think that's one of the problems we face as clinicians. I may be asked the two pediatric doctors in a minute, but I certainly sometimes am given the stool analysis of a baby of 9 months of age with a list of bacteria and asked to interpret it for both therapeutic aims and also what it means for the baby. And I'm sure you get that in adults too, Vincent. Mm-hmm. So Shannon, certainly in Australia, we get these, 20-page poo sample reports from the parent brings in with their baby. Do you get those over there, Shannon, and are asked to respond to it?
We tend not to, thankfully.
Very lucky. Sam, I know you get them. You get them every day of your working life.
I know. And then they're about this thick, Rupert, right? And then, as you say, you're trying to make heads or tails of what's going on, and I'm stuck like you. Like, so I get this sheet, this 20 thesis paper, and said, okay, so what am I meant to do with that data? Like, what practically am I meant to do to change the microbiome? Am I meant to give a probiotic or not? And the problem I've got with those studies that are done is, what was the control used? How did you work that out? Did you work it out in children, or is your control group, your reference group, adults? Did you span that? Then was it a 0-12 month? And what about 12 to 24 month? And I bet you they hadn't. I bet you it's just this generalized, this is what we call normal and this is what we call abnormal, with no stratification of that patient. So I don't take much from it. I just find that I'm confused as much as the parent of what I'm going to do with it. And then they go on a probiotic because it sounds like a good idea to, because the piece of paper tells them to.
And I think that's right. So we probably give uncertainty, don't we, Sam? You and I'll say, look, we don't really know what this means. But the thing is, and this is not to pick on anyone, because I think we're all trying to do our best for these babies. We often get quite desperate parents. I think often a homeopath will actually say, oh, well, I know exactly what this means. I know what needs to be done. And I think sometimes we come over as being a bit wishy-washy and not knowing what we're doing, whereas it's almost the homeopath who knows what he or she is doing with that data. Just to, before I go back to you, Vincent, there's a question, which I think you said this, Sam, about why do you discourage probiotics in infants with colitis symptoms? I can certainly say there's no evidence it facilitates improvement, but do you actively discourage them, Sam, or would you just say it might make it worse if you got that child who was, the mum said, I'm going to give some lactobacillus or bifidobacter to my child with allergic colitis as well as my exclusions? What's your degree of concern around that?
I think my degree of concern is there's active inflammation already transpiring, and that there's no evidence that a probiotic is all of a sudden going to stop that active inflammation. And really, it goes back to the point of why is that there in the first place? Like, what is that allergen potentially causing that problem? And what can I work out to remove that trigger instead of coming with a probiotic and then trying to fix the problem? So I've never found that by giving a probiotic in those situations, the inflammation is going to stop. And I'm concerned with active inflammation already there, that you are introducing a load of different kind of bacteria and the implications to the gut at that time.
No, I think everything you said is true. And certainly there is absolutely no evidence it speeds up the recovery of the proctocolitis related to allergy gut either. So I think you're right. And I think, once again, we're talking about your weird and wonderfuls now, but certainly, the last thing you want to do is in someone who has got immune deficiency and an inflamed gut is give them probiotics. It can be a disaster, of course, albeit a rare scenario.
Correct. Yep.
What about you, Vincent? Do you get given these big 20-page theses of bacteria?
I most certainly do. But I've got to point out one important fact, and that is that the gut microbiota for adults has been studied in much more detail than that of children. There's no doubt about that. We know that with adults, there's very large population-based cohorts. There's multiple streams of information of environmental metadata, thousands of subjects being collected. So we've got a good understanding into microbial ecology. We know about the stability, the resilience of the adult microbiota. And we do know a bit about infants, certainly in the first 3 years of age. But what we don't know much about is the variation in the gut microbiota in children over the age of 3 years. There's actually very little research on that at all. So certainly certainly I get presented with these large reports, and often there are most often dietary recommendations that you can eat this particular food, which can boost up this particular microbiota. But as you know, Rupert, that may happen, but it's not selective enough. You can eat one particular food. It may boost one particular type of bacteria, but it may lead to a decrease in another one. So the specificity of making change is really the challenge. And it's difficult to be able to give meaningful interpretation of many of these assays.
No, I agree. Thank you, Vincent. Just to go back to our patients who we started with here. So let's just say this child has got better with maternal cow's milk and soy exclusions. The mum's still breastfeeding, the child really has settled down. Solids introductions have been unremarkable, including the other high allergens that are not dairy and soy. I suppose to Shannon and then to Sam, when do you start talking about reintroductions of dairy and soy, and how do you go about asking the mum who's still breastfeeding, let's say in this scenario, to do that? So I'll ask you that first, Shannon. What do you, it's about, 8 or 9 months. The mum says, when can I start dairy and soy? Can I start it? Shall I give the baby it? What's your sort of typical introduction strategy for mum and or baby?
I mean, I guess there are 2 strategies, and I'm happy to discuss both strategies with the parents, obviously, because it's a shared decision, which is we can go slow, and somewhere around 9 to 12 months, because most of these resolve by 12 months of age, and between 9 to 12 months is not unreasonable if you've had a good period, a good few months or more of complete resolution, to start introductions. And I had this discussion with the mother the other day, kind of going, so you can either just dive in and give some milk formula, or if you want to, some soy formula first. In her case, it was just, this baby was just cow's milk protein induced proctocolitis rather than milk plus soy. Or you can, when you get to that stage, you can do it gradually. And if you want to introduce it as an ingredient first, that's fine too, and in small amounts and then increasing amounts, where if we're securing that diagnosis, we're not going to be doing any harm here, but it depends what you would like to do as mother. And she actually, to my surprise, opted for, well, at 9 months of age, I would prefer just to give some rather than do it gradually.
And do you feel, I mean, because I think I'll ask Sam what he'll do clinically, do you feel there's an evidence base, if the general pediatrician said, well, look, what should I do, Shannon? Look, I know there's lots of things I can do. What should I do? Or do you think it's not clear to us what we should be doing?
I don't think there's as much of an evidence base as, for example, for IgE-mediated milk allergy, where we're going to try and get milk and baking in first. Maybe if we don't think there's any risk of, a history of prior anaphylaxis, where we may then be able to go, okay, it looks like this is resolving in gradual introduction using milk or egg ladder, which I wouldn't do with a child with a history of anaphylaxis, just to be clear, or sensitized with no prior exposure. But I don't think the evidence is as clear for non-IgE mediated allergy.
Thank you. It's great. I think I'd probably do similar. It's very dependent on what the parent wants to do ultimately, isn't it, really? That's really important. Sam, same question to you. And do you ever ask them to go and, print off the milk ladder and stick it on their bathroom door?
Yes, I have to say I'm guilty of that. But not on the bathroom door. But I just echo what Shannon's saying, in that there is no real evidence. So if you pin me down and say, what is the evidence for a milk ladder? I'll go, I can't find one, Your Honour. Because there isn't, it's a concept that's evolved of, maybe we'll try something less allergenic, something baked, and then, you go and have some butter and then cheese, then yogurt and milk, because it sounds kind of good and sounds kind of slow, and you've been burnt by this process, so maybe we will go slow. And I do present that because most of the time the parents who have then been associated with me have had such a rough time of it all that they want to go slow. So I go, okay, it's not going to cause any harm. It's just going to take a while to go through this milk ladder approach. And at least it gives them a structured approach, Rupert, I have to say. Otherwise, if you just go and have some dairy, what's that mean? But if you give them like, this is the step, they feel a bit more in control of the situation. So I've got no problem with the milk ladder sticking on the toilet door, no problem at all. And so sometimes then I say, yep, sorry, Rupert, go.
No, you go first, sorry.
Oh, and then sometimes I say, this is just a guide. So if you don't want to do steps 1 to 5, because by the time you get there, the kid will be a teenager, you can just go to step 6, and go for the dairy. But it just gives them a structure, and that's what I like about it.
And I probably should have said this.
Sorry.
Do you? Sorry, Shannon. You go.
From my perspective, I guess I'm at that point trying to demedicalize the condition that may have resolved or be resolving by that point. But absolutely, if they want to go slow, I'm happy to give them a milk ladder.
Yeah.
And happy to give it anyway.
Agreed. And look, sorry to both of you, I probably should have been specific. Do you ask the mum to do this, Shannon? Do you milk ladder herself if she's breastfeeding, or you just go straight to the kid?
Straight to the baby.
And Sam?
Straight to the baby, and agree with Shannon, the timing, just pick a number out of your hat, but somewhere between 9 to 12 months is the time I start doing this. And straight to the baby, not to the mum.
So this is a question to both of you. It's probably only got a few minutes left, but so what do you say to the mum then? Do you say just, because I'm with you now, Sam, I'll go back to Shannon. Do you say just, eat normally, or do you want her to be gradual with her dairy introductions?
Not really. Well, I go to the baby first. I go, let's just go to the baby and see how the baby goes. And then if I say, well, the baby's doing fine and is eating the ladder okay, why don't you just put milk back into your diet now? Like fresh milk back into the diet.
Yeah, agreed. Same with you, Shannon. Do you ask the mum to, I know it's not a verb, but to milk ladder herself?
No.
Good. No, I think once again, there's no evidence for that, is there? Can I just say, I've got a question. It's for both of you. It relates to Sam's comment, but I'll ask both of you this. Back to Sam's comment about introducing solids in relation to mucus in stool. At what age could this be suggested? I think what the question is getting at is, do you do anything different in terms of timing of introduction of solids for the baby with mucousy stools, or were you just saying it's likely to get better when their transit is slowed down by solids?
Correct. It's the latter, Rupert. I think that's right. Once you've started solids, whenever the baby's developmentally ready, it's that transit. It slows it down and the mucus goes away.
Yeah, agreed. Do you and it's probably same question to you, Shannon? I guess we all know about the whole 4 months allergy reduction, but practically speaking, do you ever get babies of 4 months to introduce solids, or do you tend to wait a bit later? I suppose, what are the New Zealand guidelines on normal solids for babies? Are they anywhere between 4 and 6, or what do you do?
So between 4 and 6 months when developmentally ready. And when that baby's showing signs of wanting to eat solids.
Yeah. So I guess what we're saying is not earlier than we developmentally normal just for allergy prevention. The baby's still got to do normal Gen Ped stuff, hasn't it? I think that's... I think you see sometimes babies giving it probably for sensible reasons, but you think this baby's not even close to being ready yet. Some 4-month-old babies are not, are they? And some are. I think we all know that from our general paediatric training. I don't know if there are any other questions from the audience. We've certainly got time for a couple for our esteemed panel.
There are none on there that I can see right now.
So, Vincent, what do you see as the check? What questions do you get from your gastroenterology patients around allergy testing? Do you get asked questions around IgG testing very often?
Not always. I mean, Rupert, probably the most common question that I get with respect to allergy testing with adults is about food allergies, particularly, or better still, food intolerances in adults. So this is a very common requested test if someone has a food intolerance and they want to exclude an allergy. Now, I'm very careful in that situation to actually make the difference between a food allergy and a food intolerance, because there is a substantial difference between the two terms. And it's obviously very evident in children, but actually in adults, it's actually very, very clear that there is a difference between a food allergy and obviously a food intolerance. Although there is some research to suggest that many so-called food intolerances, there may be possibly an immunological mechanism behind that. So there is some evidence to sort of emerging evidence, you could say, but actually the entities are very different. And I think it's really important that we look at, when it comes to intolerances, we look at things like low FODMAPs, for example. I mean, these are new strategies that we're adopting with dietary management, which is substantially different from the way that we treat food allergies.
Agreed. Thank you. It's a great summary, actually. I think certainly in our older children, we often get those situations where it's not about allergy at any immune level, but it's about manipulation of diet, which almost is a topic for another day, which actually brings us nicely to our conclusion. I think our hour is up. So, look, I think thanks everyone for joining. I know that obviously this is the first of 3. Be really keen to hear the feedback. I believe there is a link. I'll ask Tash and the Nutrition team to highlight this link where you can comment on whether you like the format, what you'd like differently next time, any things that you would prefer, didn't like, happy to hear from that, and we'll do our best to adopt and change it for the next one. But certainly thanks to everyone for joining us today. Have a good evening, afternoon or morning, depending on where you are. And hopefully these things will at some point in the future be involve jumping on a plane to another country or state, but maybe not anytime soon. Thanks everyone, and thanks to all of my other members of the panel. It's been great. Thank you.